Hi everyone, and welcome to our second video on the reproductive system. In this video, we're just going to focus primarily on the female reproductive anatomy, and in our next video, we're going to go through what's going on in the ovaries, the uterus, talk about things like perimenopause and menopause, but we got to understand all of the different components that are found in the female reproductive tract first. So let's get started. So just like in our last video, this is a nice little mid-sagittal view, kind of showing you the orientation of the female reproductive system in comparison to some of the other systems we've looked at, like the digestive and urinary system. It has a lot of different structures we're going to be looking at either directly in this lecture, some that we only talk about more in lab. So let's dive in first with the ovaries. Now, one thing you should note, obviously, is that the female reproductive tract differs in one major way. There's a lot of different, but the most obvious is that all of our reproductive stuff is on the inside. Like 90% of it is on the inside, whereas again in males, they have the penis, the scrotum, testes, all of that is outside of the body. We do also have two paired glands, just like males do. They are called ovaries. So the female ovaries are where we produce our gametes, which are called oocytes, and they are homologous to the testes. Just like the testes produce testosterone, the ovaries are also producing hormones that are very important, like we talked about last chapter, with not only primary but also secondary sexual characteristics with females, and these include progesterone, estrogens. We also have some others involved in there, including a little bit of testosterone. Now, because the female reproductive system is within the pelvic cavity, just like the intestines and other components of the digestive system need to be anchored, so too do the uterus and the ovaries. So we're going to learn a lot of ligaments this lecture. First, I want to bring your attention to the broad ligament, and we'll talk about it again when we get to the uterus. But one of the ways we keep the ovaries in their sort of lateral, slightly forward position is through the broad ligament, which is this big sheet-like ligament that you see, the little bat wings, okay? There are three different regions to the broad ligament that are all named based off of what they're connecting to, the ovary, the fallopian tube, or the uterus. I'm not that concerned that you know it's called mesovarium in my class. But I do like to let you guys know so you're not confused of like, wait, there's a totally other different ligament. Nope, it's just a region of the broad ligament. And this is going to basically envelop and wrap around like in between. You can see here the ovary and the fallopian tube and the uterus. So it's going to kind of help connect it there and then connect to that lateral abdominal wall. We also have the ovarian ligament, which you can see here, that connects the ovary to the uterus. There is no passageway here. It is simply just a connection to have the ovary attached to the uterus. And then lastly, we also have the suspensory ligament, and this is fairly similar to the spermatic cord in males in that, as you can see here, here's your suspensory ligament. This is how we're bringing in vasculature, nerve supply, to the ovary. And also where we have things like ovarian torsion. So just like testes, ovaries can also twist and get that blood supply cut off. This typically happens with ovarian cysts, which we can get into more in the next lecture. But when we have this large fluid-filled cyst, it can pull on the ovary, and then that could lead to torsion, which presents in a very similar manner to testicular torsion. If we look at the ovary, it has 4 different layers to it. It is surrounded by a layer of cuboidal epithelium, and this is called our germinal epithelium, which is kind of an outer covering of the ovary. And then just like with the testes, we have a connective tissue layer, and that is your tunica albuginea. Okay, so deep to this germinal epithelium, you'll have a second layer of the tunica albuginea, again, just kind of giving structure and protection to the ovary. And the two most important layers here are the cortex and the medulla. The cortex is going to be important in our next lecture as we go through the anatomy and physiology of oogenesis. As we produce these eggs and the surrounding tissue, this is happening in the outside of the ovary, in the cortex. Deep in the ovary, as you can see here, this is where we're going to find our blood vessels, lymphatics, and nerves. They're going to be deep within the ovary, and then surrounding that is where you're going to have the eggs growing. Now, the purpose, again, of the female reproductive tract, we have to produce an egg. It needs to get fertilized, and then it implants into the uterus. That's kind of the evolutionary goal of the reproductive tract. Even though the ovary is physically attached to the uterus, it is not physically attached by like an opening for the egg to go through. So during the process of ovulation, which is where a mature egg leaves the ovary, it actually erupts into the pelvic cavity. And some women can feel this. We'll talk about it more in the next chapter. It's called Mittelschmerz. But as that fluid enters the peritoneal cavity, it can become irritating, and it is painful. So what happens is that egg is released into that abdominal cavity, but doesn't usually float around. Typically, the end of your uterine tube, your oviduct, your fallopian tube, is going to, here's my ovary, is going to kind of plop itself very close to where that ovary is, so it can catch the egg as it erupts, kind of like how a baseball player catches a ball. These little finger-like projections are called fimbriae, and they kind of help sweep the egg up into the tube itself. And the tube has 3 different regions. We have the wider part, the bell end, where the fimbriae are. That's the infundibulum. It's going to suck the egg in. Travels down that uterine tube, and then where it connects to the uterus, we call that the isthmus. Now, this is where fertilization is happening. We're going to go through that whole process in the next chapter, but this is where fertilization happens. The egg is released, and by the time the egg is released, usually the sperm will have already made it through, and they meet somewhere here in the ampulla. And this is where the process of fertilization happens. This is where ectopic pregnancies come from. So ectopic just means outside of the uterus. You can have an ectopic pregnancy in the abdominal cavity, or more commonly, they happen here in the fallopian tube. And these are problematic, as we'll talk about later, because unlike the uterus, who has this ability to stretch and expand and accommodate a fetus, the fallopian tube does not. So you can have an ectopic pregnancy, have the fetus grow, rupture the oviduct, and now you're in a life-threatening set of circumstances because you could bleed to death. So this is where, you can't replace the ectopic pregnancy and move it to the womb. This is where you would need to take medication to basically abort the fetus because it is incompatible with life. And we'll talk more about that in our chapter as we go through like pregnancy and delivery. Now, if we look at the uterine tube underneath the microscope, this is what we would see. So here's the lumen right here. This is where that egg or the fertilized egg would be found. And we can already see we have cilia here on the edge because this is where cilia really play a huge role. There is peristalsis, but there's not enough to really push the whole egg all the way. So we use the cilia and these peristaltic motions of the muscularis to move the egg towards the uterus. We also have specialized cells here called PEG cells that are providing nutrients to that developing ovum. So as it's going through all of its different stages of cleavage and blastocyst formation, it has nutrients and energy to do that. Now the egg will make its way from the oviduct to the uterus. And again, I think I mentioned this in our last video. Most women, when they're going through their cycle, females will have one ovary that goes through the cycle. So we have like maybe you ovulate on the right 1 month and then you ovulate on the left 1 month. There are always exceptions to the rules. So usually it's one side or the other, not both, but it can happen. So now we talk about the uterus. This is where the fetus will gestate for 9 months and go through the development process we'll talk about in the next chapter. The uterus has 4 major regions to it. This is again a sagittal view. Here's anterior, here's posterior. The superior rounded portion of the uterus is called the fundus. The majority of your uterus here, this is called the body of the uterus. And then right here, the portion of the uterus that sort of dips into the vaginal canal, that's called the cervix. And where the cervix and body meet, there's a region right about here, and that is called the isthmus. Now, the cervix is really important clinically because it is actually, when you look at it, kind of looks like this. It's almost like a sphincter. Isn't, but kind of is. There's an opening here. For most of the female cycle, this guy is closed. Around ovulation, it opens a little bit, the mucus becomes thinner, and it makes it easier for sperm to pass through. When you're pregnant, this also seals up, fills with what's called a mucus plug, more on that later, and it helps ensure that there's no infection getting into the uterus itself. This is also what is scraped, essentially, during a pap smear, when women are having the cells of their cervix checked for any abnormalities. This is also what is checked when you are doing, when we're looking at dilation and effacement during the stages of labor. Now, as you can see from this diagram, the uterus does not sit straight up like this. It actually lays on top of the bladder, so it's superior to the bladder, and it's in what we call an anti-flexed position. So it's kind of leaning forward over that bladder. Now, some women, some of you, or you may have heard of what's called a tilted uterus, and that's where it kind of tilts more posteriorly. It could be straight up, it could be all the way back, but it's outside of that anti-flexed position. It doesn't really cause a lot of problems. A lot of women actually have a tilted uterus and don't really know about it. It's not really involved in infertility. Most of the time, even during pregnancy, you actually do have the uterus come out of that anti-flex position. Most of the time, the reason a woman wouldn't even know that she has a tilted uterus or go to find out about it is because it can cause, because of the angle it changes the cervix, it can cause some pain during sexual intercourse. Now, the uterus, as we mentioned, is in this anti-flexed position. It has uterine tubes that need to be in a particular position. It has the ovaries that need to be in a particular position. So we are going to anchor that guy, anchor it down good. So if we anchor the uterus in this anti-flex position, I need to connect it anteriorly to that anterior abdominal wall. And the way we do that is with what's called the round ligament. So the round ligament is going to come from the front of the uterus and attach to that anterior abdominal wall. If you've ever been pregnant and you've had pain sort of on the lower portion of your pregnant belly, that is often what we call round ligament pain, because as the uterus is expanding, the abdominal wall is expanding, it's kind of pulling on that ligament, or as the uterus kind of moves about, as the fetus moves, it can pull on that ligament. We also have our broad ligament that we saw earlier with the ovaries. This is going to attach the uterus laterally to that pelvic and abdominal cavity. We also connect the uterus posteriorly to our sacrum through the uterosacral ligament. And then we have a lateral ligament down at the bottom where the cervix is, where the cervix sort of meets the vagina. And that is called the cardinal ligament. So it's going to connect it laterally down by the cervix. So here's an overview. Again, we're looking from the back now at the uterus. We can see our big sheet-like ligament here. That is our broad ligament. We see a small ligament right here towards around that isthmus area of the uterus, heading posteriorly. That's the uterosacral ligament. And then we have right here coming from the front, going anteriorly, is the round ligament. This particular diagram doesn't show where the cardinal ligament is, but it would be around this area here. Now, uterine histology is actually really critical when we're talking about the physiology of the female reproductive system, because spoiler alert, it changes throughout a female's cycle. Now, there are 3 layers to the uterus. We have the outer layer through which all these ligaments are attaching, called the perimetrium. Most of the uterus is made of smooth muscle, and we call that the myometrium. This is what's responding to oxytocin during contractions in labor. This is also what is contracting and causing menstrual cramping during your menstrual period, because it's kind of trying to squeeze all of that dead tissue out of the uterus. The inner lining is the part that changes throughout a female cycle. So we'll talk about this a lot in the next video. Lots of vasculature here because this is where the fetus is going to develop. And we don't know where the blastocyst or morula, that's just going to actually like embed. So the whole uterine lining has to change and make itself available for a fertilized egg. The endometrium has 2 layers. The deepest layer, just like the skin, the stratum basal, the deepest layer of the endometrium is called the stratum basalis. This is never sloughs off. It's always going to be inside your uterus, and this is where we kind of regrow the uterus from. So it's just like the stratum basal of your epidermis. The stratum functionalis, this is the functional layer of the uterus. This is what's going to get thicker, get glandular, get vascular, and then if you don't get pregnant, it's what sloughs off. It's what you're seeing in those tissue and blood clots during menses. So here's a cross-section of a uterus. We're going to get to look at this in lab. Here is the lumen of our uterus, and this big thick layer here is the endometrium. And we can see this layer down here, stratum basalis, and the area up here we can see a lot of cross-section of like spiral arteries and glandular tissue. This is the stratum functionalis. That's what would slough off during menstruation. We have the big thick myometrium and this really thin outer covering of the perimetrium. Now that is all of our internal sort of main areas of physiology. That is where we're going to have the egg develop. That's where the egg is going to travel, and that is where the fetus is going to develop. The vagina is also internal, and its main job is it's an entry and an exit point. It is a very muscular tube that can actually stretch, obviously, because a fetus has to go through it. It's incredibly flexible, and it extends from the vaginal opening on the external surface of the vulva all the way to the cervix. That is your vagina. It has 3 different layers, the mucosa, which is on the inner portion. This is a actually really important area because the mucosa here is actually going to create an acidic environment. Because the vagina is just open to the external environment, we don't want it to be an area for a lot of bad bacteria to grow. One of the biggest things that happen with women is yeast infections, and that's because the balance of the pH, the acidity, within their vaginal canal is changed. It's often due to things like douching, which you don't need to do. Your vagina does that on its own. It can come from infections, or it can also come from your diet as well. Some women are more prone to get candida infections, so that's what a yeast infection is. And then its outer layer that's connecting it to other things in the pelvic area is going to be your adventitia. So as we can see, here's the opening to the vagina from the outside, and this is what it looks like on the inside. It's just this muscular tunnel, okay? Now, most young women will have a piece of tissue around the vaginal orifice that we call a hymen. It partially closes the vagina, and most women don't know they have it. Sometimes you will notice its presence during your first time having intercourse because you might have some bleeding afterwards as the penis basically has broken it or whatever else has intruded upon the hymen. But it can become a problem because there's a lot of different iterations for the hymen, and if a young woman has one that completely closes the vaginal opening, that becomes a problem when she starts menses, and so there might need to be some surgery involved to remove the hymen simply so that her endometrium and the blood can exit. But other than that, it's just a piece of tissue, and I don't really know why we have it. So the outer genitalia of a female, again, this makes up a very small percentage of our reproductive anatomy. This is called the vulva. And I really, really want to emphasize the outer structures are the vulva. The tube going to the uterus is the vagina. I hear that misconception a lot. People will point at, hey, this is your vagina. Well, that's the vaginal opening. You're looking at the vulva. The vulva contains a lot of different structures. At the top here, because the woman is laying down, this is where we have what's called your mons pubis. It's actually a pad of fat that's on top of the pubic symphysis and actually cushions it, okay? And then sort of surrounding the vaginal opening, we have two fleshy structures. The outer sort of fattier structure here, this is where you have pubic hair. This is called the labia majora, and this is homologous to the scrotum. So if this individual had the genetics to become externally, primary sexual characteristics of male, the labia majora would have become the scrotum. As we move more medially, we get the thinner, more like fleshy structures, which are called the labia minora. These do not have pubic hair on them, and they come in all different shapes and sizes. There's actually a wonderful project that was done, I believe, in the UK that actually categorized all the different types of vulva that women have, because this is often an area of stigma for a lot of women, and it was just very empowering to see that there are different things that are considered normal. So if you're interested, I think it's called the Vulva Project. I can't remember. Ask me in class. Now, these labia minora are actually homologous to the spongy urethra. So again, this tissue would have wrapped around and become like a circle like this to become the spongy urethra in the males, to go around it. Now, the clitoris, if we look here, this is at the anterior-most aspect of the vulva, and it is homologous to the glans penis, which again is the tip of the penis. This is where you have all of those nerve endings that are very important for excitement in terms of producing an erection through physical contact. Just like the glans penis, it's also covered by tissue that we call the clitoral hood. So both the glans penis and clitoris are important for stimulation to produce, in the case of males, the erection and then the eventual climax to produce ejaculation. And in females, it's to help produce lubrication within the vagina for penetrative intercourse. There are glands, we're not going to get into them because we don't really see them in our models, but there are glands on the outside of the vagina that actually produce secretions to increase the lubrication for penetrative intercourse. Now, between the vulva and the anus, there is a region here of skin called the perineum. Why are we talking about the perineum? Because during childbirth, this area can get damaged. Now, is every woman that has a vaginal delivery going to tear? No. It depends on your genetics, your nurses, and sort of your pre-childbirth preparation, okay? A lot of times, especially during the first child, women will tear simply because their bodies just aren't prepared for it. And tearing actually often happens more so not because it's your first delivery, but if it happens really fast and you progress really quickly and the baby's out, that can lead to tearing. So there's 4 different degrees. First degree is where you just tear just the tiniest little bit. You might need 1 stitch. No problem at all, okay? Typically, you won't even recognize that you have torn. Second degree is the most common one, which is where you are going to have a deeper tear. It's going to get into some of the muscles of the perineum, and you are going to need some stitches. This is not going to feel good while you're recuperating from a vaginal delivery. Third degree is where you tear very far and you start to get into the anal sphincter. Now remember, the anal sphincter is what keeps the feces within the anal canal until it's time to defecate. So injuring that can lead to problems with defecation. The final and most severe perineal tear is going to be here, which is 4th degree, where you extend all the way through and you rupture the entire anal sphincter. This often is going to require reconstruction, as you can imagine, because you have torn through a muscle. So this is going to require a much more extensive healing phase. I really want to reiterate, that's not how all births go. So it's rare, but it can happen. Now, you guys have probably also heard of something called an episiotomy. An episiotomy, they're not done really much anymore. It's kind of an old school technique, but it was thought that if we preemptively cut the perineum, it will make healing better. We'll cut it, the baby will come out, we'll stitch it all together, and it'll be easier for the woman to heal. When in reality, our bodies are supposed to do this, and they found that women actually have better healing and less pain if they go through a perineal tear, like a first or second degree tear, versus just like, let's preemptively cut with an episiotomy. There are obstetricians that do these still, but not everyone. And you can always advocate for yourself and say that that is not something that you would like to do. All right, the last thing we need to talk about in terms of female anatomy are breast tissue. So females have breast tissue because one of our evolutionary roles with producing the next generation is we also provide sustenance to them until they can get their own food. So mammary glands are where you're going to produce colostrum and milk, and we'll talk more about what that difference is when we get to pregnancy. But basically, you're going to be producing a fluid that has sugar, fat, protein, water, everything that new baby needs to grow and develop. Some women don't have the ability to produce milk, and that's okay. I was one of them. Formula is totally fine. That is best. The breast itself is basically built as a homing device. So we have the areola, which is the darkened circle that surrounds the nipple. The nipple has holes in it for the milk and colostrum to come out of. It's basically made here in these mammary glands, goes through the lactiferous ducts and then out through the nipple while you're breastfeeding. And this is all happening because of oxytocin. Prolactin, remember, is the hormone that's going to help with the production of milk. The areola is important, especially for newborns. Those of you that have been pregnant before probably did notice there were changes in your breasts, besides the fact that they got larger as they filled with milk. Your areolas get larger and darker because newborn babies don't have very good eyesight, and this helps them visualize where they need to go to find the nipple so that they can eat. So that's why your areolas change prior to and during breastfeeding. So that is it for female reproductive anatomy. I'm going to see you guys in our last video for this chapter, where we go through the entire process of how eggs are made, the tissue surrounding the egg and why those are important, and then putting it all together for the female cycle. So I'll see you then. Bye.